In this week's session, I'd like to address the subject of steroid injections for plantar fasciitis. I was asked to present this topic at the annual New York State Podiatric Medical Association meeting. This is a rather expanded version of that discussion. I thought it was an intriguing question to explore. Many podiatric physicians readily employ corticosteroid injections for the treatment of plantar fasciitis. I've always tended not to be an injector, at least not on initial visits. I don't think it's wrong to do that, obviously. Most people do treat plantar fasciitis with initial injections. So people have, I think, various approaches to this. Steroid injections into the plantar fascia for the treatment of heel pain has been a standard part of the treatment of heel pain for quite some time. This was a study from 1994 in Foot and Ankle International looking at 100 patients treated for plantar fasciitis, and injection therapy was included as a part of the standard treatment, together with some type of heel padding and stretching, reduction in activity level, and the use of an anti-inflammatory. And as you could see, the success rate was close to 90% at 10.9 months. And one of the things that I always feel is important is to talk to patients about treatment of heel pain, and specifically the fact that this is seldom a problem that resolves overnight, that typically it takes quite a number of months to totally resolve the issue. And we talk about comorbid conditions such as the need for weight loss and so forth. But corticosteroids have always been a big part of the treatment of heel pain. If we look at the preferred practice guidelines of the American College of Foot and Ankle Surgeons, corticosteroid injections are included as part of Tier 1 therapies, meaning initial therapies during the first 6 weeks, as well as Tier 2 therapies, meaning therapies administered for the first 6 months. Conversely, if we look at this particular survey, which was a survey of American Orthopedic Foot and Ankle Society members, this was published in 2012, we see that there's less enthusiasm for the treatment of plantar fasciitis with corticosteroid injections than there is in podiatry. And you can see that only 6% of members of the American Orthopedic Foot and Ankle Society recommended the use of corticosteroid injections in recalcitrant heel pain at 4 months. I've always found it fascinating that plantar fasciitis or plantar heel pain is an entity which seems to respond to a number of varied treatment approaches. And if we look specifically at injection therapy, I think it is fascinating to note the diverse, the eclectic array of injectables that have been published as being helpful for the treatment of heel pain. We have certainly steroids. There are those that have advocated the use of injectable anti-inflammatories. There are studies that have suggested that the simple use of local anesthesia, absent any corticosteroids, is sufficient. We have dry needling techniques where nothing is injected, but a needle is passed back and forth through the plantar fascia. We have numerous papers suggesting that botulinum toxin injections are helpful for the treatment of heel pain. Autologous substances such as platelet-rich plasma, venous blood have been advocated for the treatment of plantar fasciitis. Various sclerosins, the injection of mesenchymal and stem cells, prolotherapy. So we see a diverse array of things that have been injected into the heel for painful inferior heel pain, and advocated and supported by studies. If we look at injection therapy for the treatment of plantar fasciitis, this was a study from Current Reviews in Musculoskeletal Medicine, noting that all types of orthotics appeared to improve inferior heel pain. Stretching seemed to be helpful for both short and long-term improvement in heel pain. There's equivocal data for the use of extracorporeal shock wave therapy. Again, botulinum toxin has been reported as being associated with good short and long-term therapy. Iontophoresis has been shown to be associated with very significant short and long-term benefit for the treatment of plantar fasciitis. Steroid injections have been reported as being associated with both short and long-term benefit and is helpful for pain relief. So why inject corticosteroids for heel pain? Well, for one thing, we know that the literature shows they provide short-term pain relief. They've been shown to be as or more effective than many of the alternatives that we discussed. It is less expensive than most alternatives, such as botulinum toxin or stem cell injection. It's something that we can provide in the office rather easily, and there's really a low incidence of side effects reported. Well, why not use corticosteroids? Well, in recent years, we've seen arguments that what was called plantar fasciitis is really not plantar fasciitis, that many of these patients are in fact manifesting plantar fasciopathy or plantar fasciosis, and that they are not demonstrating an acute inflammatory process, but rather a chronic process. We have the potential for complications with the injections, such as flare reaction. There is a reported incidence of plantar fascia rupture. Occasional stress fracture has been reported. Injury to the lateral plantar nerve has been reported. There's the potential for complications such as infection, and we do have occasional publications talking about cellulitis, even osteomyelitis or necrotizing fascial infections occurring after plantar corticosteroid injections. With repeated injections, certainly there's the issue of soft tissue atrophy and loss of the plantar fat pad. Occasional patient with pigmentary alterations, and then patients who occasionally get systemic adverse sequelae from injections. So while anyone who's been in private practice for a long period of time knows that these side effects are uncommon, they have been reported. Looking at risk factors for plantar fascia injections, this was a study published in 2014 looking at 35 cases of plantar fascia rupture, and in 33 of those cases the patient had received a prior injection of corticosteroid, the authors recommending that such injections be administered with some caution. Another study looking at plantar fascia rupture, this was a podiatric study, Bob Mendocino and Al Catanzariti and others looking at 120 patients who had plantar fascia rupture, and the majority of these patients had actually received multiple steroid injections, and out of 120 patients, 4 had sustained a rupture after an average of about 2.67 injections. This was a study of 765 plantar fasciitis patients. 51 were diagnosed with a rupture, and of the 51, 44 were felt to be secondary to a steroid injection. Interestingly enough, the patients who sustained a rupture generally went on to resolve their plantar fasciitis, probably due to a self-induced plantar fasciotomy effect. Another study looking at 37 patients with heel pain and steroid-associated plantar fascia, most common sequela being pronation-associated changes, dorsolateral foot pain, almost equivalent to a post-fasciotomy complication, some persistent swelling, metatarsal pain, occasional metatarsal fractures. So we have a low but defined incidence of complications associated with steroid injections. What about the argument that this is fasciosis or fasciopathy and really is not an inflammatory process? I think most of the enthusiasm for this approach grew out of the work by Harvey Lamont, who looked at 50 histologic specimens of patients who underwent plantar fasciectomy. And he noted that histologically, the changes that were present, such as myxoid degeneration, chronic degenerative changes, were consistent with chronicity rather than an acute inflammatory process. And it was Lamont's conclusion that this was therefore not an inflammatory process. Interpreting this at a clinical level, therefore, one would want to argue, then why would one want to utilize anti-inflammatory therapy for something that's not an inflammatory process? And indeed, This has been used as an argument by more aggressive members of the profession to say, well, let's go ahead and do surgery at an earlier time, because you're just wasting the patient's time with anti-inflammatory therapy. Since this is not an inflammatory process, let's just go about and approach this surgically. Certainly, this does not explain the close to 90% of patients who have traditionally responded to non-operative care, including corticosteroid injections, without the need for surgery. I thought this was an interesting paper published by Marty Pressman and his associates out of Connecticut, and they looked at 100 pathology specimens of their patients who had recalcitrant heel pain and underwent plantar fascia release, and they went ahead and obtained specimens for histologic examination. So generally these were patients that had heel pain which remained recalcitrant for at least 3 months, generally 6 months without response. And 25% of the specimens actually showed changes consistent with plantar fibromatosis. 21% of the specimens showed inflammation, and about half the specimens showed no inflammation or neoplasm. And this study is some cause for thought, because we tend to lump all plantar heel pain as being plantar fasciitis, absent some obvious additional problems such as inferior calcaneal bursitis or stress fracture or some such thing. And this diversity in histologic findings in the Pressman study, I think, gives us pause to realize that not everyone's going to respond to the same therapy, because not everyone with inferior heel pain has the same pathology. So we're looking at some patients that probably do have, in fact, an acute inflammatory process, and other patients that have a more chronic inflammatory process, and we have different histopathologic findings as a result of the difference between those presenting with acute and those presenting with chronic inflammatory disease. Now, this concept of plantar fasciopathy, plantar fasciosis, as opposed to plantar fasciitis, would of course then argue, or at least potentially argue, against the use of corticosteroid injections. But what it doesn't explain are findings on studies in which ultrasound is utilized, and there are many of these studies. So typically when we look at modern studies on treatment of plantar fasciitis, we frequently are looking at patients who undergo ultrasound studies, less frequently MRI studies, but certainly ultrasound studies, and we look at some of the characteristic findings for plantar fasciitis, which include hypoechogenicity and increased thickness of the plantar fascia. And if we look at patients who undergo treatments, in this case, for example, steroid injection therapy, ultrasound guided, we see that in response to steroid injections, there's decreased thickness of the plantar fascia, and there's a resolution of the hypoechogenicity, which would imply a decrease or resolution of the inflammatory component. So that if this were not a dynamic process, we probably would not expect to see decreased hypoechogenicity, nor would we expect to see a decreased thickness of the plantar fascia. This is another such study from 2011. The authors looking at plantar fascia thickness and response to injection and mechanical therapy. Here again showing that with successful mechanical therapy and with its successful injection therapy, there was decreased thickness of the plantar fascia. This particular study was published in Journal of the American Podiatric Medical Association, again looking at ultrasound studies pre and post treatment. And here again, 3 out of 4 patients showed decreased thickness of the plantar fascia on ultrasound study, and that decreased thickness in the plantar fascia correlated with decreased pain reported by the patient. So again, we have multiple studies that look at this as a dynamic, ongoing process rather than a static process. So do steroids work? What about this particular study looking at steroids versus placebo? And they also looked at ultrasound versus non-ultrasound guided injections. Non-ultrasound guided injections being, I think, rather typical of the average podiatrist, where we look for tenderness to palpation, tenderness to touch, and inject in these areas. And there was no difference in outcome either by pain reported by the patient or in reduction in plantar fascia thickness between ultrasound guided injections and non-ultrasound guided injections. And the study showed that corticosteroids were clearly superior to placebo. So we learned two things from this study. One was certainly that corticosteroids likely are helpful for some patients with plantar fascia pain. And number two, this particular study suggested there was no benefit to ultrasound-guided injections. This particular study from Journal of Bone and Spine in 2005 looked at long-term follow-up of steroid injections in 47 heels of 30 patients. Again, these were not ultrasound-guided injections. They were palpation-guided, but ultrasound was utilized to follow these patients. And it was noted that after 1 month, both pain and thickness of the plantar fascia reduced significantly in patients who underwent steroid injection, and further decrease was noted at 6 months and correlated again with reduction in pain, so that these authors concluded that steroids had a good long-term effect. This was the most recent examination of this question. It was published in the Cochrane Database of Systemic Reviews, and they looked at a variety of reference sources. 39 studies qualified. 36 of those studies were random controlled trials. 3 were quasi-random controlled trials. A total of almost 2,500 patients were looked at. And typically these were patients who were injected, as we typically do in our offices, with steroid and local anesthesia. The Cochrane database study pointed out that it's difficult to draw conclusions. Most published studies utilizing steroids or steroids versus some alternative were small studies. The follow-ups were between 1 month and 2 years, so tremendous variability in looking at short-term versus long-term benefits. There was generally a high risk of bias in these studies, particularly with the comparator agents. There was almost always a lack of blinding of the examining physicians, and generally studies for steroid injection and similar injections of comparator agents were considered to be low-quality studies. In two of the studies involved use of a posterior tibial nerve block. 4 studies, the use of orthotics, oral anti-inflammatories. 1 study, injectable anti-inflammatories. 5 studies with platelet-rich plasma. 5 studies qualified for extracorporeal shock wave therapy, and so forth, including 1 study of cryopreserved human chorioamniotic tissue, 2 studies with Botox, dry needling and needle fasciotomy, and so forth. The conclusions of these studies are that they tend to show that steroids are helpful for pain relief in the acute setting, meaning about 1 month relief of pain compared to placebo or no treatment. But generally, as I said, the studies were regarded as being low quality studies for the injection of steroids versus alternatives. So while we're heavily marketed with alternatives for corticosteroid injection, keep in mind that most of these studies are regarded as low quality studies, low numbers of patients, unblinded examiners, and so forth. Similarly, while there are many who advocate using only ultrasound-guided injection, there's really no strong evidence to suggest that ultrasound-guided injections are in any way superior to unguided injections. And we do have calls, I think a lot from practice management organizations and seminars advocating techniques to generate increased office revenue to utilize ultrasound-guided injections for just about everything. And if there were some defined benefit to justify the increased cost, that might be a reasonable consideration, but we really don't have the data to support that. Lastly, the Cochrane database suggested that while serious risks, consequences, complications from corticosteroid injections are reported, they're not reported probably as frequently as they did tend to occur. Now, looking at steroid injections and the use of ultrasound guidance versus palpation guided, is there evidence that again, ultrasound-guided injections are preferable and the increased cost is justified? And we've seen the Cochrane database, we've seen other studies that you were just presented to say, no, we really do not have any evidence in comparator studies to show a benefit to ultrasound-guided injections. I thought this was an interesting study from the Journal of Ultrasound Medicine. It was a cadaver study, and they utilized ultrasound-guided injections of a color latex preparation deep to the plantar fascia and reevaluated the cadavers at 72 hours. And they wanted to know, where does this material go? And it showed that there was contact with the flexor digitorum brevis. There was spreading in the distribution of the lateral plantar nerve, and particularly the Baxter nerve. So even if we have accurately injected that patient with an ultrasound guided injection, that material doesn't stay there. It spreads out. So for example, if you were trying to discriminate a Baxter nerve entrapment from, say, plantar fasciitis, you couldn't do it by saying, well, I gave an ultrasound guided injection, I was specifically injecting the area of the heel spur, and if this had been the nerve or some other pathology, the patient likely would not have responded. That's certainly not consistent with the studies that we have available. Again, looking at a comparison of palpation-guided injection versus ultrasound-guided injection for heel pain, there was no statistical difference shown in this particular study in plantar fascia thickness, in fat pad thickness, or in patient-reported visual analog scales to pain. So it's difficult to justify ultrasound-guided injections. This particular study was from 2006 in the Journal of Clinical Ultrasound. It looked at 25 patients with ultrasound-guided versus palpation-guided injections of betamethasone and lidocaine. The criteria were VAS and tenderness to touch at 2 weeks, 2 months, and 1 year. You could see that reported pain relief was reduced in both groups. Tenderness to touch was reduced in both groups. Plantar fascia thickness was reduced in both groups. Hypoechogenicity was reduced in both groups, but the recurrence rate was apparently higher in palpation-guided injections than in ultrasound-guided injections. So here again, we have very limited, if any, basis to suggest that there's a benefit on ultrasound-guided injections. This was a very recent publication published this year in Journal of Foot and Ankle Surgery, looking at whether or not we should inject superficial or deep, and plantar fascia thickness, pain improvement, and function improvement was looked at, and the injections were administered either superficial or deep to the plantar fascia, and these were evaluated by several scales, including Likert scale, FAOS sub-scale. Both groups, superficial and deep injection, demonstrated decreased plantar fascia thickness. Heel pad was unaffected in either group, although it was felt by the authors that overall there was greater improvement with the injection administered deep rather than superficial, period. What about selection of injectable? This was a study looking at methylprednisone and lidocaine versus dexamethasone, and looking at improvement in terms of no pain, mild, moderate, or severe pain, and methylprednisolone appeared to provide better short-term relief than did the dexamethasone. Is there a benefit to a posterior tibial nerve block? This was examined in 2 particular studies. This is one of the 2 that was published in Rheumatology. showing that there was really no advantage to a posterior tibial nerve block in association with injection of the plantar fascia. What about using a physical therapy program together with corticosteroid injections? So this was a look at stretching with and without steroid injections, rather steroid injections with and without stretching, and there was ultimately no difference in outcome from either of these groups. This particular study looked at corticosteroids versus extracorporeal shock wave therapy, which is of course a much more expensive management technique for inferior heel pain, again advocated by some. This was a look at 125 patients who had pain greater than 6 weeks. They looked at tenderness to touch and pain as the endpoints. All the patients had stretching. They either had low-dose extracorporeal shock wave therapy or they had single corticosteroid injections. And the result of this study demonstrated corticosteroid injection was actually more efficacious and obviously less expensive than extracorporeal shock wave therapy. This was a particular study looking at autologous growth factors versus corticosteroid injection in 64 patients. They were examined over a 6-month period of time. Again, looking at patient-reported VAS and tenderness to touch, and while both were effective, corticosteroids were felt to be superior. Some have advocated autologous venous blood injections for the treatment of plantar fasciitis. It's kind of an interesting study looking at steroids versus autologous venous blood injections, and 2 groups, as you could see, 21 with steroid injections, 28 with autologous venous blood injections, and interestingly enough, there was no statistical difference between the 2. We have very strong advocates for platelet-rich plasma injections, and again, we're talking about a substantial increased cost versus corticosteroids in the office, and the question here is there an advantage to platelet-rich plasma over corticosteroid injections? This particular study involved 60 patients. Methylprednisolone with prilocaine was utilized versus PRP with prilocaine. The patients were examined at 6 months using Rolls-Maudsley scoring. There was no difference in outcome. Looking at steroid versus platelet-rich plasma, in this particular study, the authors suggested that platelet-rich plasma offered an attractive alternative to corticosteroid injections. This particular article involved 50 patients. They underwent VAS and ultrasound studies for plantar fascia thickness and echogenicity, and as you could see at 3 months, there was no difference in outcome. So while the authors noted that platelet-rich plasma is safe for injection, there was really no superiority to it, and the conclusion was that it was not inferior to steroids. And while that may be true at a clinical level, it is certainly not true in terms of cost effectiveness. This particular study, on the other hand, from Acta Orthopedica, looked at steroid versus PRP in 50 patients and noted that platelet-rich plasma appeared to be superior to steroids for long-term relief of pain and long-term improvement in function, although both steroids and local anesthesia, or PRP and local anesthesia, improved the patients. Another study published in 2015 looking at PRP versus steroid at 3, 6, and 12 months suggested that at 12 months patients had a more durable outcome from platelet-rich plasma injections. Looking at steroids versus Botox injections, this particular study from 2013 in Foot and Ankle International suggested that botulism toxin was superior, gave more rapid and sustained relief. We also see needling techniques such as the mini scalpel technique versus steroids, and in this particular study, steroids were noted to provide relief only in the short term, whereas mini scalpel fasciotomy provided more rapid and sustained relief than did the steroids. We mentioned dry needling, and here again In the long term, dry needling versus steroids, the authors concluded that dry needling provided more long-lasting relief. A study looking at joint mobilization and stretching versus steroids noted no difference, and long-term effects were consistent with both joint mobilization patients as well as the patients with steroid. We've also seen some recent papers advocating radiation therapy for the treatment of plantar fasciitis. This particular paper looked at radiation therapy versus steroid, noting that radiation therapy appeared to be superior to steroid injections at 3 months and at 6 months. So what is the role of steroids in the treatment of plantar fascia pain? Well, as you've noted, the Cochrane database suggests that the papers looking at steroids versus comparators, or looking at steroids, are generally of poor quality. They are generally low numbers of participants. You have some significant degree of bias in these patients. The examiners were not blinded. So it's difficult to draw firm conclusions in these papers, particularly with reference to steroids versus more expensive agents. And we want to keep in mind that we're talking about a significant increase in cost when we move away from steroids into these other agents. The papers do universally seem to suggest that corticosteroid injection is effective for short-term pain relief. The papers also seem to suggest that steroids plus additional therapeutic endeavors are more effective than steroids alone, or the therapeutic efforts such as physical therapy alone. There's a low reported incidence of complications with steroid injections, although it was suggested in the Cochrane database review that the incidence of adverse effects may be underreported. Certainly, corticosteroids are less expensive than the majority of the alternatives that you might consider. However, the major criticism of corticosteroids as isolated therapy appears to be that the long-term benefit is lacking. And so long-term benefits appear to be limited when corticosteroid injections are considered alone and not with other agents. So I thank you for your attention to this matter and your participation, and hopefully this provides you some additional thoughts regarding corticosteroid injections and treatment of plantar fasciitis.